We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to The Pinch of Salt, a podcast proposed by the ERA. I'm George Kosmadakis, your today's host, and the subject of the podcast is sex and gender disparities in the epidemiology and outcomes of chronic kidney disease. Repeatedly, data from all over the world, including the most developed countries, are revealing profound sex differences in detection, recognition, and monitoring that persist over time. Women are less likely to receive a CKD diagnosis, to visit a nephrologist, to have basic lab tests, or to receive guideline-recommended therapies. These perplexing issues are to be discussed today with Professor Adeera Levin, head of the Division of Nephrology in the University of British Columbia and Executive Director of British Columbia Provincial Renal Agency in Canada. Adeera, welcome to The Pinch of Salt.
Thank you.
Well, I will start straight away with the first question. What are the important sex differences in kidney health and disease?
Well, I think there are so many. Where shall I start? Maybe I'll start with the kidneys themselves. And I think that maybe not everybody realizes that the renal mass, cortex, and the proximal tubule is larger in males than females. The renal medulla is larger in females versus males. There's a whole number of differences in expression of transporters, water channels, and organic anion transporters. And even the endothelial receptor density is greater in females than males. We know that there are sex differences in sodium reabsorption and SGLT2 expression, such that females have more of these than males. And so if you imagine just that basic renal physiology is different, and that's before you put in sex hormone receptors that are studied in different cell types and the effect of sex chromosomes, that just begins the biology, right? We know that women have increased adverse effects when they take medications, perhaps for a number of reasons, which I'll get to in a moment, but there's different drug bioavailability, different body composition, and different volume of distribution. Maybe something less well known to people is that not only is the metabolism different, but our gastric emptying and gastric pH and the renal clearance, for all the factors I said before, are all different in women. So these combined as biological differences start to begin to let us hear and perhaps understand better why there might be differences in disease expression, disease prevalence, and of course, disease outcome.
Right. So there is a difference in anatomy, in biology, and probably in risk factors?
Yeah, well, risk factors as we document them. You know, one of the things that's interesting, if you look at the European Heart Association, they've been looking at whether or not even our cutoffs for hypertension in young women might be wrong, because in fact, young women under the age of 35 have lower blood pressures than men. And so if your threshold for diagnosing hypertension is 140 on 90, and yet the usual blood pressure for a woman is less than 120, you will miss hypertension if you wait till it gets to be 140. So with respect to risk factors, yes, risk factor is hypertension, but what is that magic number that makes people at risk? So I think there are a number of things that we need to challenge in our current thinking around thresholds and targets, and a single threshold irrespective of whether you're a male or a female, whether you're young or you're old. And I think that that's part of the challenge of understanding these sex differences.
Right, and there are also a lot of differences concerning the outcomes.
Yeah, so women are there. If you look at a general CKD population, men and women have maybe an equal prevalence of impaired kidney function or GFR, low GFR. But if you look at dialysis populations, men are more likely to go on to dialysis. Men are more likely to receive a kidney. Women are more likely to donate a kidney. Interestingly, there are some studies that demonstrate that compared to a general population, women on dialysis are more likely to die of cancer and gastrointestinal diseases and cardiac diseases than men. And maybe that's because they present differently or people are looking for them differently. That whole notion of what is surveillance for a man versus a woman for certain diseases at different times may in fact be quite different.
Yeah, well, I was always asking myself why I see so many women in the outpatient clinics, and I don't see an equal number of women in the dialysis unit. And I was always asking myself whether this female population is presenting a bigger percentage of mortality, or we are very good doctors and we conserve them away
Well,
from dialysis
Well,
for a
it's a
longer
great
time.
question. So one of the things that I think women are less likely to choose dialysis, right? Often because they're widowed by the time they get there and maybe they decide not to. In certain countries, they don't get a choice, is the truth. But also we do know that women progress less quickly than men to dialysis. And because we undercall a lot of their cardiac disease, they may well die of a cardiovascular event before they end up on dialysis. There are a number of interesting studies that show that women present differently for an acute myocardial infarction, that the troponin T levels need to be adjusted for male and femaleness. And if you use the wrong cutoff, you will miss acute coronary syndromes. And obviously, if you miss an ACS, people will end up having a higher mortality. So I think it's confounded and it's complex as to why there are less women on dialysis, but it's both choice and perhaps dying of other things due to lack of appropriate diagnoses.
Right. So, from what you say, it is a different kind of mammals in the end, and nobody's shocked when we have different guidelines concerning the different races due to the genetical profile, and we don't think a lot about the biggest difference of all, which is the sex difference. Very very interesting. What about the treatments? You said about SGLT2 density.
Well, it's interesting, so what happens is drugs are developed and they are developed often using male animal models more than female animal models. And then they're tested in studies where, again, there are more men than women in the studies. And then you get into post-marketing and women, perhaps because of the wrong doses or et cetera, are more likely to have adverse effects than men
Yeah.
and come off the medications. There's a couple of recent studies looking at the prescription of SGLT2s inhibitors in men and women, and despite similar indications, women are less likely to be prescribed an SGLT2.
Why?
I don't know. I think when I gave a talk once, someone said, well, because people are worried because they have urinary tract infections, that
Right.
might be a rate limiting step. But I reminded people that in all of the large studies, urinary tract infections were not different between men and women. It was the mycotic genital infections that's different. And I know that theoretically we think that it might be because of that urinary tract should be increased. But if someone has a baseline frequency of UTIs and they don't go up on the SGLT2, I would keep them on it. But I think people are nervous and they just say, oh, they all already have lots of UTIs, I won't bother. I think that might be one of the things. And as I said, because these drugs are often less well tested in men than women, then often our doses might be wrong, or the adverse effects that we attribute to the drug might be wrong. I think these are a number of things that happen in real practice.
Wow. It's really revealing what you are saying. So, what are the barriers to understand the sex differences? Why are so far away from understanding what you are saying is very original, very true, and at the same time we don't discuss about it.
Yeah, I think the very barrier is that perhaps we just ignored it or taken for granted. Like, as you said, we know that men and women have different biochemical and hormonal makeup, and yet we have not paid attention to that in health and disease the way we should have. So the first barrier is awareness. And then the second barrier is helping us to study, like even more recently, there are some in Nature and other scientific publications, there's a call to ensure that you have male and female animals, male and female derived cells when you're doing your fundamental science. So we start with beginning to remember, or reminding ourselves that there are differences. I think that's the first piece. Then consciously trying to put equal numbers of men and women into clinical studies is really important. Now, there are barriers to that. Women are also often the caregivers, not just of their young family, but also of their older family. They may, in certain cultures, not be as educated or accessible to come to multiple study visits. So I think we need to figure out what are the things that are stopping women being in studies, what are the things that are stopping us as a community studying women and embracing the fact that men and women are different, and alerting ourselves and truly figuring out, the way that we say, oh, I wonder what the CRP is. Do we wonder what the estrogen, progesterone, and testosterone levels are? No, why not? Like, why are those three things that we've ignored, even though we know the importance of hormones in vascular tone and regulation and all these and bone health? We know all these things, and yet we have never really seriously considered them in the complexity of kidney health and disease.
Well, you have started answering my next question, which is how can we overcome this barrier? So I understand that you of course, we should be sensitized for the fact that men are different than women and women are different than men, but we should have any different guidelines. We should have should we have different guidelines concerning diagnosis, concerning our drug testing, concerning should we devise our practice and our research concerning the chronic kidney disease?
Well, I mean, I suppose the simple answer is yes. I mean, we really should think through all these aspects when we're listening. I think when you listen and a woman says she's incredibly fatigued and maybe a little bit short of breath, well, the cardiologists now think, like, if you look, they have HFpEF, right? And yet we didn't used to think that. You wait, when they don't talk about crushing chest pain, they talk about fatigue and some shortness of breath. And these are the people that end up with coronary disease. So the cardiologists are starting to pay attention and talk about sex differences in presentation, diagnostics, and therefore treatments. And I think we need to get to that same level of sophistication.
Yeah, I heard the cardiologist once say that the coronary disease in women is a nightmare due to the diameter of their coronary arteries, which is much smaller than men.
And what's interesting is their complications post-cardiac intervention are higher. Why? Because all the tools that were developed developed for male anatomy, not for female anatomy. And so until you start to say, well, of course, like, it's interesting, we know the difference between children and adults, and we have very much customized treatments and our thoughts and diagnostics to children with Z scores and other things like that, but we've not thought about it in terms of male, female. And I think I'd be remiss if I didn't also talk about the fact that, sex is no longer just a binary concept, but it's also more fluid than that. And in a world where people are on gender-affirming hormone therapy, that adds yet another level of complexity to our diagnostics and our treatments, and even the estimates of GFR, which, as you know, become complicated in that context. So I think it's become an area of interest, an area of research, and an area that, we really need to pay attention to.
Right. So if you want to sum up, can you give three pieces of advice concerning the ways of overcoming these barriers?
Attention to the fact that there are physiological differences between men and women, males and females. When drugs aren't having the effect that you want, or there are side effects, think about the differences in metabolism and volume of distribution. Instead of just stopping a drug that you think is causing something, think about a lower dose or a different interval that would respect this difference in physiology, metabolism, etc. And be alert to biases that you might have in terms of diagnostics and understanding, and try and be very inclusive and thoughtful in terms of the total physiology of a human being that includes more than our usual thing. What is the blood pressure? What is the usual blood work? And think about the interaction of hormones and sex hormones with other hormones and other biological processes when you're trying to figure things out. I think if we all did that on a regular basis, we would ask ourselves more questions and get more answers.
Ask yourself questions to have even more answers. That's a wonderful, closing remark concerning the scientific questions. And now, Adeera, you're in Vancouver, which is always voted as one of the top 3 towns with the best quality of life in the world. But we'll take you away from Vancouver and we'll ask you the question whether what would you take with you in a desert island concerning a book, 2 songs, and a luxury item.
Aha. So the book I would take is The Night Circus by Erin Morgenstern, one of my favorite books. The songs I would take is Leonard Cohen's Hallelujah and Simon and Garfunkel's Sounds of Silence. And the luxury item I would take that's a harder one for me. Maybe a fantastic bottle of wine.
Right. Cohen, Simon Garfunkel, and Bob Dylan are the top 3 choices of the nephrology community. So you are
Maybe we're
in.
all of a certain vintage, who knows?
Fair. Thank you. So, dear colleagues, as you see, we have a lot of work to do in the quest to offer equitable diagnostic and therapeutic options in our female patients. We hope this podcast may sensitize the therapeutic community to be more proactive concerning the female renal health. We hope you enjoyed the discussion as I did. Professor Levin, thank you very much for being with us today. It was wonderful. More podcasts are available on all known platforms. Thank you for listening.
Great.